You so much. It's a real pleasure to be here and to be sharing with you the WHO recommendations for the health sector response to violence against women. I'm just going to take a second to share my screen. Yeah. Okay.
Yes, Dr. We can now see your screen.
Now you can see the screen, right?
Yes, yes.
Okay. Okay. Just to give a little background to this, WHO's recommendations on the health sector response to violence against women or gender-based violence come from a fairly rigorous process of developing WHO guidelines, which requires us to do systematic reviews of evidence, convene a group of experts that look at the science and then form recommendations based on the evidence. And that's then the basis for which we issue these guidelines. So these guidelines that I'm going to share with you are based on following that process. So just as a quick backdrop, as many of you will know, violence against women takes many forms. Intimate partner violence is the most common form of violence experienced by women worldwide, and I'll show some epidemiological data. But just to acknowledge that this violence takes forms during the life course of girls and women. So when girls are young, there is child abuse, neglect, female genital mutilation, child marriage. When girls mature into adulthood, there is child early and forced marriage, acid throwing, sexual violence, sexual harassment at school or work in public. There's online violence, there's trafficking, and then there's intimate partner violence. And also the most extreme form of violence is femicide or murders of women because they're women. And then in the older ages, there's always elder abuse with women who live longer, also disproportionately affected by elder abuse. So with that, just to say that the most common form that we know epidemiologically is IPV or intimate partner violence. In 2021, WHO published estimates on intimate partner violence and non-partner sexual violence. And what we saw is that overall, we are looking at almost 1 in 3 women experiencing either physical and or sexual violence by an intimate partner or sexual violence by somebody other than the partner. And there is really, as you can see from this map, no part of the world where this is not prevalent. Probably the most highest prevalences are in Asia Pacific, in the Pacific Island countries, as you can see in Melanesia, Micronesia, Polynesia. You can see very, very high levels of lifetime prevalence, which is the outer circle, where it is the outer yellow circle is around 39, 41, and 50%. Whereas the inner circle is prevalence in the past 12 months, and again, 30%, 20% roundabouts. In the WHO Southeast Asia or Southern Eastern Asian region, lifetime prevalence is around 21%, and the past 12 months prevalence is around 9%. And in the Southern Asia, it is around 19% in the last 12 months and 35% in the lifetime. We also know now that the health effects of intimate partner violence are quite grave. So in 2013, WHO, South African Medical Research Council, and the London School of Tropical Medicine published health impact estimates of intimate partner violence. And we looked at the pathways by which these health impacts bear out. One is physical trauma. And we saw that the data from systematic review showed that 42% of women who have experienced physical or sexual violence at the hands of the intimate partner experience injuries as a result. The other pathway is psychological trauma or stress. And we saw that women who experience intimate partner violence are twice as likely to experience depression, almost twice as likely to have alcohol use disorders. And then the third pathway is fear and control. where women who experience partner violence have limited sexual and reproductive control and also are less likely to have autonomy to seek health care. And here what we saw is that they are 16% more likely to have low birth weight babies, twice as likely to have an abortion, often in very unsafe conditions, 1.5 times more likely to acquire HIV, and 1.5 times more likely to contract syphilis, chlamydia, or gonorrhea. Importantly, if you look at murders, 38% of all murders of women globally were reported as being committed by their intimate partners, as opposed to 6% of murders of all men. And we also saw data that showed that women experiencing IPV were 4.5 times more likely to attempt a suicide. So as you can see from this slide, we're looking at a very, very serious health burden of intimate partner violence as really the reason, one of the first reasons why we know health sector has to really get involved in responding to violence against women. Based on some of this prevalence evidence as well as the health impacts, in 2016, the World Health Assembly and the Ministries of Health endorsed a global plan of action for health systems to address violence against women and girls and violence against children. And that this particular global plan of action mandates ministries of health to really act on 4 pillars. The first is around leadership and governance, and really having ministries of health put in place policies and protocols and budgets and really speak out about violence. The second pillar of this global plan of action is to provide services and train health workers. The third pillar of this global plan of action is around actions ministries of health can take with other sectoral ministries to foster prevention. And the last one is really around surveillance and improving the data collection through administrative data, but also supporting prevalence surveys. So these are the 4 areas in which we have specified actions that governments as well as the health sector actors can take to address this issue. Why the health systems? And really it's because we have data that shows that women who experience violence are more likely to use health services. They may not disclose this violence to health providers, but they will present with these very non-specific symptoms, or sometimes, as I showed you, coming back for repeated STIs or repeated pregnancies. And that's probably an indication that there is something happening in the lives of these women where they are presenting again and again with health conditions. We know when health providers are empathetic and provide survivor-centered care, that women will prefer to disclose violence to health professionals and trust them much more than any other sectors, including the police. And we also know that women are likely to seek health services for reproductive, maternal, newborn child, and adolescent health care at some point in their lives. So they will present to the health services for family planning, for antenatal care, for delivery, for child immunization, for child care, for postpartum care, throughout the life course. And so that is a particular opportunity that healthcare providers have to actually proactively think about how they will be in tune with the signs and symptoms of violence and ask women about this issue. So what is the role of the health providers? It's very basic in the sense of it is do no harm. It is to identify violence. It is to provide immediate first-line empathetic response by listening without judgment. Of course, the clinical care for signs and symptoms. Referrals that women want, specifically for other services. To document the violence in the health management information systems. To generate medical legal evidence where women do want to report to the police and go through the court system, and to be advocates, because many health providers are community role models in their communities. Communities often look to health professionals as a source of information that can be trusted, and therefore they can be really good advocates. what we do say is that providers are not responsible. And this is important because it's important to understand the boundaries of what providers are not necessarily mandated to do. They're not responsible for solving all of the violence-related issues and problems the woman faces. They're not responsible for solving all of the violence-related needs. And they're not required to address all aspects of treatment, care, and support in one single consultation. The most important things providers can do is to build that empathetic trust and relationship with the survivor so that she will keep coming back and express whatever needs she wants over time. So that is perhaps one of the most important things to do at the first consultation, is to build that trust, a trusting relationship with the survivor. So what do the WHO guidelines say? They provide recommendations in 6 areas. The first is what we call woman-centered or survivor-centered care. And the recommendations are really around minimum offering of what we call first-line support, which is empathetic listening, non-judgmental attitude, and making sure that the consultation is done in a private space and confidentiality is ensured. The second set of recommendations are for intimate partner violence survivors. It is to identify and should ask about violence while assessing conditions that may be caused or complicated by IPV. So if you see injuries, for example, or you see repeated pregnancies, or you see repeated STIs, or you see non-specific complaints or psychosomatic complaints like headaches, sleeplessness, sometimes irritable bowel syndrome, which are not having any physiological explanation, then you may want to ask about IPV in a very empathetic way, because that will help you then have importantly proper diagnosis and treatment. The third set of recommendations are clinical care for survivors of sexual violence, where in addition to first-line support, emergency contraception, STI and HIV prophylaxis, and then taking complete medical history and reporting the events so that the survivor can decide what she wants to do. The next set of recommendations are for health managers and policymakers, and that is to ensure that health workers are trained not only in service, but also at pre-service. So in schools of medicine, nursing, midwifery, to be able to respond and support survivors who've experienced both IPV and sexual assault. The next recommendation is around models of service delivery. And what we do recommend is that services for violence against women should be actually integrated as much as possible into existing health services, existing as in antenatal, family planning, maternal health, mental health, rather than actually being provided as standalone services, and particularly at the primary healthcare level. And the last set of recommendations are around mandatory reporting to the police by healthcare providers. And we actually recommend that mandatory reporting should not be actually put in place, because women should make those choices. They are the best judges of their own safety and situation. And so the onus should be on health workers to actually offer to report if the woman desires or if the woman wishes to do so, and then facilitate the reporting if the woman wants to. So just to get into specifics of what women-centered care is, it is really respecting women's self-determination and respecting the woman's wishes about the care she wants, the safety issue, which is do no harm, and then ensuring privacy and confidentiality and providing the best possible care, and recognizing that at heart, violence is about power imbalances. So you actually, as a health worker, have an obligation not only to recognize this power imbalance, but do your best to mitigate it as much as possible, or at least not reinforce it. For identification of IPV, WHO does not recommend universal screening, but it does recommend clinical inquiry, which is based on signs and symptoms. And then before you ask about IPV, WHO's recommendation is that there should be minimum requirements to be in place in the services. So the health provider has to be trained in how to ask and offer first-line support. there has to be a protocol or a standard operating procedure. There has to be a private consultation room, a confidentiality procedure, and some sort of a system for referrals in place should the woman want to be referred to other services. So these are the 5 minimum requirements before health workers are encouraged to ask about or identify intimate partner violence in women. What is first line support? I think it is boiled down to 5 steps, which is through the acronym LIVES. And it is about listening closely with empathy without judgment, inquiring about women's needs and concerns, validating their experiences by offering non-judgmental response, enhancing their safety. So conducting a safety assessment and then planning and supporting with her what she could do to increase her safety in her home. And then if she wishes, supporting her to connect to other services as she wants, but also there may be informal sources of support that women may have through peer networks, through friends, through family, that actually she may want. So that is the nutshell job aid of what Lives is. And it is really about health workers communicating in an empathetic way. We have a pathways for care, a protocol, an algorithm for how to care for survivors of intimate partner violence. So it is really around treatment of injuries if needed beyond first line support. If there are mental health conditions, then to refer to a mental health specialist. Of course, depends a specialist if they are trained in cognitive behavioral therapy or eye processing, eye movement desensitization and reprocessing, or EMDR. For those with PTSD is also recommended. And brief to medium duration counseling, empowerment counseling, up to 12 sessions may be also offered. But we know that these are often in very high income country settings. So at least, making sure that she has the basics of first line support and psychosocial support in low middle income country settings is important. But where you might have moderate to severe depression or PTSD, to identify where she can get mental health support is important. For sexual violence, the algorithm is really around making sure that in the first 72 to 120 hours after sexual assault, there is not just first line support, which is essential, but taking complete history, doing a physical examination. And if the woman presents within the 72 hours to 120 hours, emergency contraception, HIV post-exposure prophylaxis, and STI prophylaxis should be offered. If the woman is not vaccinated for hepatitis B, that should be another vaccination offered. And safe abortion to the full extent of the law if the woman becomes pregnant as a result of a rape. And also making sure that she's provided information for strategies of dealing with anxiety and stress. And then after the first 120 hours, any follow-up treatments are around mental health care. So first line support, watchful waiting, and if symptoms of PTSD or depression emerge, then there should be some referrals for mental health treatment as per MHGAP, and that is really CBT and EMDR. For training of health providers, the WHO recommendations in detail should be that health providers should have received training in first line support, and also when and how to inquire. So what are the signs and symptoms on basis of which health workers should inquire, how to respond. And most importantly, what we found is that attitudes of health workers that may actually pose a barrier to women trusting them and disclosing to them should be addressed. Many of us come from societies and communities where we carry forward our own set of attitudes towards survivors that may stigmatize or blame them, and we need to be cognizant of that. And to make sure that it's not just training one-off, but there's continuous supervision and mentoring. And we also recognize that many health workers who are doing this work themselves may experience trauma and burnout. So really to put in place mechanisms that support health workers who are doing this work to deal with their own trauma and burnout, and making sure that it's integrated into, as I said, schools of medicine, nursing, midwifery, etc. what we realized is that, it is not just enough to train health workers, but it's important to put system-wide changes. And that includes, for example, improving procedures around patient flow that can lead to a privacy and better confidentiality, making sure that the health management information system is allowing documentation, and that there's constant quality assurance, which means monitoring and evaluating service readiness and improvements. So training alone is not enough. You have to have system-wide changes, health service readiness changes to enable the health workers to carry out this clinical care. We have developed since these recommendations many practical tools. There is a medico-legal guidance for sexual violence survivors. There's a clinical handbook for how to provide lives and first-line support. There is a health manager's manual for how to actually put in place systems for privacy, confidentiality, develop protocols in place. And then there is a training curriculum for both health workers and health managers face-to-face, as well as through an e-learning, where health workers can go in online themselves. And I've provided a link here below, where they can go and practice some of these skills themselves through animation and all sorts of interactive tools. And we also have guidance on how to integrate this content of the curriculum into pre-service training, and how to monitor quality for service delivery. And for health policymakers, we now have a defined package for including healthcare for IPV, for intimate partner violence and sexual violence, in universal health coverage that can also contribute to costing of these services. In addition to the health sector response, we also recognize that prevention is important. And you will remember that there is the WHO Global Plan of Action asks health sector to work with other sectors to promote prevention. So we have provided evidence-based prevention for policymakers into 7 strategies, which is called RESPECT. And this R of the RESPECT stands for interventions to promote strengthened relationships, the E for empowerment of women, S for services, P for interventions that reduce poverty, E for interventions that improve safe environments, such as safe public spaces, schools, and workplaces. The C of that is for child and adolescent abuse prevention. And the T of RESPECT is for interventions that transform gender norms, beliefs, and attitudes in communities. So RESPECT is a complement to all of these health sector response tools to actually help the health sector and the other sectors come together and put in place a comprehensive multi-sectoral prevention package as well. So I'll end here by just saying that we have recognized over the many years of implementing all of these tools is that it's really small changes that make a big difference. And this is a quote from a Salvadorian woman that says, "The doctor helped me feel better by saying that I don't deserve this treatment. And he helped me to make a plan to leave the house the next time my husband became violent." So thank you so much for this. And I'm happy to take questions after this panel is over. Over to you.
Can you see my screen?
Yes, we can see.
Also, please excuse me. There is a little bit of background noise because there's some construction work that's happening on the floor above. So please bear with me and tell me, if it's disrupting the quality of sound.
No, we didn't hear any noise from the background.
Okay, okay.
Thank you.
So I'd like to begin a little bit about the organization that I belong to. Like I said, that we are a Bombay-based organization in India. It's called the Center for Enquiry into Health and Allied Themes. The organization has recently completed 30 years of engaging on different issues that impact the health of marginalized communities in India. And one of the issues that we work very closely is the issue of gender-based violence and its linkages to health. My presentation will largely focus on lessons learned from implementation as well as implementation research. As Dr. Avni has comprehensively presented the recommendations laid out by the WHO for low and middle income countries, CEHAT has made an attempt to implement those on ground and also research the extent to which the implementation has been successful, challenges that we have been able to find, and also try to plug in the gaps as far as the policy environment in India is concerned. I will largely speak about two models. One is about setting up a hospital-based crisis counseling center for survivors of gender-based violence in a public hospital. And the second looks at setting up a model to respond to rape survivors and develop gender-sensitive guidelines for medico-legal care. So the word dilasa means reassurance in Hindi. This is a Hindustani word. And from the outset of this model, it was always envisaged as a department of the hospital, as an outpatient department, just like we have different departments such as the emergency, the surgery, and so on. Because at the outset, the thought process was that this should be considered as a counseling outpatient department in a public hospital. This was initiated about 24 years ago. I think this was I think it was close to the time that the WHO and UN bodies had declared the issue of violence against women as a public health concern. And it was the same time around which this experiment began in India. I would like to draw your attention to the fact that in 2000, India had not defined gender-based violence as a health issue, leave alone a public health issue. There were no laws in the country at that point in time which demanded a specific responsibility of the health sector. And that is why I have listed it as an experiment over here. 6 years into the implementation, it was then called upon as one of the good practices, especially for low-income country settings where resources are very limited. And that is when the entire advocacy campaign began with CEHAT and many other health and women-led organizations on the issue of integrating a health sector response to violence against women. Currently, this program is running in 6 different states in India. Yeah. So since the outset, the model, which is called as Dilasa, was always envisaged as a public-private partnership because we believed that after the experiment was over, the responsibility lied with the government of India to be able to provide these services. So there were a couple of methodology that was used in order to implement this partnership. The responsibility of CEHAT was to conduct a training of trainers program because it's a large hospital. There are more than 800 employees of the hospital. It is beyond a single organization to be able to equip and train 800 plus employees. So a selection criteria was implemented to select individuals from the organizations from different cadres, such as doctors, nurses, support staff, and others. This was done purposively to break the hierarchy, which is very strong in health systems. We co-created standard operating procedures for how is it after training that doctors, nurses, and support staff will identify survivors of gender-based violence within the hospital settings, both inpatient as well as outpatient, based on the signs and symptoms. And based on both of these issues, what is the nature of evidence that can be generated based on health consequences of violence, based on outcomes of the psychosocial crisis intervention services provided? At the same time, there was a need felt to have a dedicated cadre of social workers trained to provide psychosocial services. As you've all seen in the previous presentation, that the role of a healthcare worker is to sensitively identify and respond, but they are not really trained to provide crisis counseling services. So the hospital had to create a cadre of social workers who were trained to provide those services. the expectation of the non-governmental organization, which was CEHAT, from the government was to ensure that they assign a nodal officer at the level of the hospital who can provide oversight to all the work that is related to the issue of gender-based violence, whether it's about assigning training, whether it is about conducting monitoring committee meetings, whether it's about ensuring that a certain systematic documentation is carried out, and so forth. It was also to ensure that the gender-based violence response becomes a part and parcel of the routine activities of the hospitals. As you will all know that the hospitals have different methods of carrying out medical education-based trainings on a quarterly basis. There is skill enhancement trainings that are carried out on a quarterly basis. Similarly, when new doctors and nurses enter a public hospital, they also go through an orientation program. So CEHAT's role was to ensure that each of these different trainings have a component of responding to gender-based violence. Similarly, the counseling department had to be assigned a status of an outpatient department if it was to become a part of the hospital services. So there was a peculiar name which was called an OPD 101, which was given to the Dilasa Counseling Center, and formats were created for referral system within the hospital. Finally, there was also a need for creating monitoring mechanisms to assess whether the quality of care that is being offered to survivors of sexual and gender-based violence is up to the mark or not. And that is why an MOU, Memorandum of Understanding, was created between CEHAT and the public hospital, where we were provided access to different documentation registers of the hospital to actually analyze the quality of documentation and raise any concerns if there were with the administrative authorities. These are some of the pictures related to the trainings that are being carried out in different hospitals. As you see, most of the trainings that are implemented at the level of the hospitals have to implement adult learning methods to keep interests of healthcare workers going. If you see the numbers, the Dilasa has been now listed as OPD 33A. So these are different images from different hospitals about training as well as the crisis center. This is a slightly different model, which is called the Mukta model. Mukta is, again, an Indian word. It means freedom. This model was initiated in collaboration with the World Health Organization and CEHAT, as well as two medical colleges in India. This was really to kind of assess the implementation of the clinical and policy guidelines developed by the World Health Organization, especially for countries like India, to see if it is possible for the health system to create a gender-sensitive response to survivors of gender-based violence. So these hospitals, though did not have full-time social workers, they did create different mechanisms to be able to provide what we call as the lives model, the first-line care for all survivors of gender-based violence. And interestingly, because of the trained healthcare providers, of the 533 women that were identified and responded to in a span of 9 months in these places, almost 54% of healthcare workers felt comfortable asking women about signs and symptoms related to violence. In addition, almost 44% women felt comfortable disclosing violence to the healthcare worker. So this is an important lesson for many of us to learn, that if healthcare providers are equipped and trained and supported with basic infrastructure, it is possible for them to identify and provide the first-line care support to survivors of gender-based violence. This is a snapshot of what is expected from healthcare workers in India. It ranges from identification of abuse, as mentioned in the previous presentation, ensuring that there are basic standards in place about ensuring confidentiality of information, having a private space to ask women about gender-based violence, documenting the violence in medico-legal formats, which are again gender sensitive, and ensuring that there is no victim blaming documentation that is done. A part of it also comprises of what is called as gender sensitive medico-legal examination, providing women with additional information about impact of violence on their health, as well as providing them information about emergency shelter services, police aid, legal aid, as well as a helpline. And then, in addition to doing all of this, they could either refer women to a hospital-based crisis center such as Dilasa. In the absence of a hospital-based crisis counseling center, they could refer them to the existing hospital social workers for basic support. What is it that the Dilasa team of social workers do in a public hospital-based counseling center? To begin with, they provide what is called as feminist counseling services. The term feminist counseling services indicates that women who report any form of violence are not blamed for the conditions in which they face violence. Rather, there's an entire discussion of the gender norms and roles around them that put them at high risks of facing violence. They're also assisted with registration of police complaints. There is free legal aid that is provided. In our experience, 70% of women ask for legal advice, but not even 5% of them actually access litigation, which is formal litigation in the courts. All women who are in the public hospitals accessing these services are assessed for their safety. This is not just physical safety, but it's also psychological safety, because 1 in 5 women at the Dilasa Counseling Center have attempted suicide in the past and have been admitted in the hospital for an accidental consumption of poison, which often, when counselors speak to these women, we realize is that they're actually attempts to end their own lives. And that is why safety assessment forms a critical part of the counseling services provided here. Once a woman is discharged from the hospital, or if she's seeking services at the outpatient level, she's provided telephonic support. So the Dilasa teams run a 24/7 helpline service for women who've accessed the counseling services. In addition to this, the social workers of the Dilasa Center are trained in active case identification, and they do their daily rounds in the outpatient as well as inpatient departments. They go to different wards speaking about the role of violence and its connections to health, and kind of promote accessing services at the level of the counseling department. This is a quick snapshot to indicate where is it that the Dilasa department, the Dilasa counseling department receives survivors from. So largely they receive women and girls facing violence from within the hospitals, which is outpatient, inpatient, and so on, as well as the HIV/AIDS counseling department where ART services are provided. Almost 10% of women accessing Dilasa service come through the IEC materials. These materials are displayed in women's toilets, in OPDs, and so on. As well as you can see that emergency department is an important factor. Because the Dilasa departments have now been across 11 hospitals in the city of Mumbai, there's a huge amount of awareness in the geographical communities. And so about 25% of women accessing services come from the communities. This is a snapshot of the Dilasa model. I'd like to draw your attention to a second model, which is comprehensive response to sexual violence. The demand for creating a gender-sensitive response to rape survivors came from within the hospitals who were already implementing the Dilasa model. While we began our work with responding to the issue of domestic violence, it was the healthcare workers who started saying that the way in which rape survivors were being responded to in public hospitals was absolutely pathetic. There was no standard protocol for responding to rape survivors, and they were unhappy with the way in which the response was being provided to them. So this, I wouldn't call it the current scenario. This was the scenario almost 7 to 8 years ago, where you see that there is a lack of uniform procedure in the management of sexual violence. All rape survivors were mandatorily reported to the police. It was only after the police requisition that they would initiate the medical examination of sexual violence. Most often, providers did not have the skills to be able to probe for details, such as the history of sexual violence. Often providers thought that penovaginal sexual assault was the only form of sexual violence against women. They did not have the language to ask about different forms of sexual violence. There was mechanical evidence collection. So the evidence collection from the body of a survivor was not really related to the history. Rather, it was like a tick box where all forms of evidences were being collected. In many Asian countries, including India, there was a huge preponderance of the two-finger test, comments on hymen, and so on, which were all a part of the unscientific medico-legal examinations. And despite going through this entire rigmarole of medico-legal examinations, most healthcare providers were unable to provide a reasoned medical opinion after their examinations. There was also a complete gap of communication between the forensic science lab, the police, and the hospitals. And so often, when doctors reached the court, they had no substantive medical opinion to provide. We also noticed that though they were all healthcare workers and often doctors, there was a preoccupation with their forensic role and they continued to ignore their therapeutic role. It was in this context that a new model had to be created. I'm sure many of you would be aware of the 2012 case called the Nirbhaya case that took the entire country to storm. And that was really a time that there was a recognition that there is something not quite right with the way in which rape survivors were being responded to, not just by the health institutions, but across different institutions. And at that point in time, there were a couple of elements that came to be known as comprehensive elements for rape care. They begin by obtaining informed consent, a detailed documentation of the history of sexual violence, gender-sensitive examination that does not comment on the finger test, that doesn't comment on irrelevant aspects such as hymen and so on, collecting only the relevant forensic evidence pertaining to that particular sexual violence, providing a reasoned medical opinion, ensuring that the survivor receives medical support and that too free of cost. She should not be charged for it. Ensuring and mandating that she receives psychological support or at least psychological first aid at the level of the public hospital. It also mandated creating a foolproof chain of custody. So from the time the evidence from the body is collected to its dispatch, there was a chain of custody that was created within the hospitals about who will collect evidence, who will store the evidence, and who will hand it over to the police. And finally, appropriate referrals to legal and shelter services. In the situation of implementing comprehensive healthcare response at the level of public hospitals, our role was more technical in nature because there were already established Dilasa centers. So it was about ensuring that doctors and nurses were trained in seeking informed consent and conducting gender-sensitive medico-legal examinations. We also initiated a round-the-clock helpline dedicated to healthcare workers so that they could contact us at any point in time when they face challenges. A mechanism for monthly meetings was set up to go over the filled out medico-legal proformas to understand what were the existing gaps in responding to sexual violence. And then, of course, also encourage and assist healthcare workers to start publishing about the good practices that were there. Because at the end of the day, it's important for us to also recognize that what is in it for healthcare workers to do this kind of work. So CEHAT has consistently created different opportunities for healthcare workers to be able to present their work in different fora, to be able to write about their work, and to be able to publish this in important journals. This is a snapshot of the expectations of doctors in rape care. And I'm specifically saying doctors because in the Indian context, the medico-legal authority vests with an MBBS doctor who has been defined as a registered medical practitioner in India. So it's only her who is vested with this role of documenting the history of sexual assault and conducting thorough medico-legal examination. However, she can bring on board other, healthcare workers such as nurses and so on, but the overall responsibility rests with the doctor. Just to end by saying this is a beginning, and though we have been engaged in this work for almost 2 decades, we realized that it's important for gender-based violence to become a part of the pre-service medical and nursing curriculum, because often at the level of the hospitals, you're already working with healthcare workers who have completed their education, and they do come with a certain set of norms or a certain structured thinking, which does become difficult sometimes to deal with. And so it's important that all of these aspects be brought into the pre-service curricula so that younger minds can be influenced positively. It's also important that the gender-based violence healthcare response be embedded in the quality of care in hospitals. All the public hospitals in India, as well as private hospitals, have to undergo a routine quality assessment on a yearly basis, and gender-based violence healthcare needs to come into that and formulate a part of the quality of care in hospital assessments. And finally, much more evidence needs to be generated on the impact of violence on health. Though we do have publications coming from low and middle income countries, there is a pivotal need for generating more evidence on the health impact of violence against women. Thank you. And I have a very short video to present to you based on a collaboration with the World Health Organization, a project that was initiated in rural India. So I would like to share that with you.